Good afternoon, everyone. Thank you for joining today's webinar, exploring the latest SABCS 2023 data, new insights into MammaPrint and BluePrint, presented by Dr. William Audeh. During the webinar, if you have any questions, feel free to submit them using the Q&A button. And if we have time at the end, we'll be sure to address them. Otherwise, if we can't get to them, we will follow up via email. Now, I just want to give a brief introduction to Dr. Audeh before I hand it over to him. Dr. Audeh is the Chief Medical Officer at Agendia and a medical oncologist specializing in breast cancer with nearly 30 years of experience as a clinician and clinical researcher at the Cedars-Sinai Cancer Center in Los Angeles. Prior to joining Agendia, and in addition to his clinical practice, he served as the former director of the Cedars-Sinai Cancer Center and medical director of the Wasserman Breast Center Risk Reduction Program. Dr. Audeh has been principal investigator on a wide variety of national and international clinical and translational trials and has authored numerous publications in the field of breast cancer, cancer genomics, and targeted cancer therapy. With that, I'll hand it over to you, Dr. Audeh.
Well, thank you very much, Karen, for that kind introduction. And thank you all for joining us this afternoon as I walk through the data presented at the San Antonio Breast Cancer Symposium in December of last year, revealing new insights into MammaPrint and BluePrint. There were multiple abstracts with which Agendia and our collaborators participated to bring to the San Antonio meeting a spotlight poster, as well as numerous others that were presented. And so what I'm showing you here is the list of abstracts. One of these was not specifically new Agendia data, but rather a reanalysis of MindAct versus TaylorX. And if there is time, I will review this. But my main focus are all of the other posters, which describe data derived from our FLEX study. And I would just want to take a moment to describe that to you. FLEX is a real-world evidence study in which patients who are stage 1 to 3 breast cancer, non-metastatic, of course, who are undergoing standard of care testing with MammaPrint and BluePrint, with IRB approval and patient consent, at the same time that we obtain the MammaPrint and BluePrint, we actually obtain the full transcriptome from the tumor sample that we receive. We also annotate this with several hundred clinical data elements, all going into a common database. And within this database, any of our investigators can suggest sub-studies relating to any aspect of breast cancer, clinical behavior, and biology. We conduct this trial throughout the United States. We have sites in Canada as well as in Europe. And we refer to this as the FLEX Study Breast Cancer Consortium, with, as you can see, over 100 sites, 11 NCI-designated cancer centers, several hundred physicians, and now I'm happy to say nearly 16,000 patients enrolled in this trial with stage 1 to 3 breast cancer and whole transcriptome data, which makes this an extraordinarily valuable and unique database with several years now of follow-up. So with that, let me review some of the data that came from the FLEX study. The first is a characterization of the MammaPrint ultra-low risk cohort, looking at over 1,400 patients in the FLEX database. First author on this study was Dr. Kathy Graham from Emory. Here is that poster, and let me focus on the main points. We undertook this study to look at the clinical characteristics of this genomic category, ultra-low risk, which has been identified within MammaPrint. and with prior publications has been shown to have an exceptionally good prognosis and quite indolent behavior. And the question was, are there clinical characteristics that might identify these patients separately from genomic identification? So for this purpose, we looked at 1,465 patients within the FLEX database. What you're seeing at the top are some of the clinical features of these patients. You can see 83% were over the age of 50. Again, the majority postmenopausal, the majority being white women, and of course, over 80% receiving only endocrine therapy. I think the interesting thing is to look here at the further clinical features that characterize the ultra-low risk category within MammaPrint. Most of them are clinically low risk, as you can see, 79%. Most of them are T1 tumors, and most are node negative. I think it's important to point out, however, that they are not all grade 1. 56.5% are grade 1, but over 40% are grade 2 tumors. There are even some grade 3. And then in the last group of columns there, Ki67, while the majority are less than 10% or less, a significant number are over 10%. And I think the conclusion here is that 1 out of 5 patients that are ultra low risk had high risk clinical features. A number of them were under the age of 50 and premenopausal. 1 in 5 were T2 tumors. As I mentioned, over 40% were grade 2 or 3, and a third had Ki67 over 10%. And so I think it's clear that one needs genomics to identify these truly indolent tumors, which you cannot base on clinical factors alone. Again, reiterating that 1 out of 5 have high-risk clinical features. Many of them are younger women, and as we know from the MINDAC data, ultra-low-risk women who were 50 years and younger had no evidence of any benefit from the addition of chemotherapy. The second abstract I'd like to review with you is analyzing another important clinical category, and that is the HER2-low hormone-positive subset of breast cancer. Of course, everyone understands that the HER2-low category is of great interest because of the antibody-drug conjugates that are now entering the clinic in the metastatic setting to treat these patients. And we were interested in the genomic profile of these patients and whether specifically they indicated a separate and unique biology. Here is the overview of the poster. The objective of this trial, as I mentioned, was to look at the genomic features of HER2-low breast cancers by MammaPrint and BluePrint, as well as whole transcriptome, which allowed us to do differential gene expression. We looked at nearly 1,700 patients who were defined by routine pathology as being HER2-low, meaning, of course, IHC1 plus and FISH or ISH negative, or IHC2 plus and FISH or ISH negative, and comparing these to true HER2 zeros, which were the category used for the comparison. When we looked at the clinical characteristics of these patients between HER2-low and HER2 negative, we saw no significant differences between them. And then when we looked at the genomic characteristics, there were really very few, if any, differences. However, one important distinction is to note that within the HER2-low category, over half were low risk genomically by MammaPrint. And this becomes important when one thinks of the effect of the antibody-drug conjugate as really another way of delivering chemotherapy. And is a genomically low-risk tumor really in need of chemotherapy treatment, regardless of the manner in which it's delivered? We did see a small difference in the basal subtype when we looked at BluePrint. Not surprisingly, the HER2 zeros were more likely to be triple negatives as well, which is reflected in that increased percentage of basal subtypes. The power of the FLEX study with whole transcriptome data is that we can do whole transcriptome differential gene expression between groups of cancers, looking for any difference in gene expression, where we would say that a greater than twofold difference is statistically significant. And when we looked at the difference between HER2 low and HER2 zero, we found no significant differences in either over or under expression of any genes. Basically, no transcriptional differences that we could detect between HER2 zero and HER2 low. So the key points here are that HER2 low and HER2 zero do not appear to differ clinically or genomically. And this study confirms what other groups have shown, which is that HER2 low is probably not a separate clinical entity, but rather an artificially defined subset with a low level of what is now a new target for antibody drug conjugate therapies. One might argue, however, that if these drugs were to move into earlier stage breast cancer, that genomically low risk patients, which made up over half of the HER2 low group we studied, may not really need chemotherapy, despite the fact that they could be targeted with an ADC drug such as Enhertu. And as I mentioned, 53% were low risk tumors, which we believe do not need chemotherapy to begin with. So if and when these agents move into early stage breast cancer, I think these data argue that there needs to be some sort of genomic profiling beyond just the presence of HER2 low, the HER2 low category, to determine whether these women really need this kind of drug. Going on with the analysis of clinically defined subsets was, I think, a very interesting and comprehensive analysis, which we did with, in coordination with the I-SPY group, looking at MammaPrint, BluePrint, and the I-SPY defined response predictive subtypes, specifically in lobular breast cancer, with Dr. Rita Mukhtar from UC San Francisco as the lead author here. Here is the poster itself. So, as I mentioned, the goal of this study was to look at the distribution of response predictive subtypes, in addition to MammaPrint and BluePrint, of course, in lobular breast cancer. The response predictive subtypes, imprint and reprint, I think have become increasingly important in looking at differential response to immunotherapy, PARP inhibitors, etc. For this study, we looked at over 1,000 women with hormone-positive, HER2-negative invasive lobular breast cancer, in addition to 418 with tumors that were described by the pathology report as mixed, ILC and IDC, and compared them to nearly 6,000 pure invasive ductal cancers, all enrolled in the FLEX study. When compared to invasive ductal cancer, not surprisingly, patients with invasive lobular cancer were older, had lower Ki67s, higher T stage, as we know that the clinical behavior to be, lower grade, and therefore higher clinical risk based upon T stage and nodal status, but also less likely to receive chemotherapy. Most lobular cancers, not surprisingly, are MammaPrint low risk, but many are high risk, and we have already shown from other cohorts, including the MINDAC data, which are in the process of being published, that a genomically high-risk lobular cancer behaves with the same level of aggressiveness as a high-risk ductal cancer. So looking at MammaPrint distribution on the far left with ILC and mixed ILC, IDC in the green and blue columns respectively, you can see that the proportion of invasive lobular cancers that are high-risk MammaPrint is much smaller than low risk. And we also see virtually no lobular cancers reaching the high 2 category of MammaPrint. When we look at the blueprint distribution, not surprisingly, the vast majority are luminal by blueprint, meaning, of course, they have evidence of intact hormone receptor signaling. And those that are MammaPrint high 1, of course, fall into the category of luminal B. Again, a much smaller proportion than those which are MammaPrint low risk and luminal, otherwise luminal A. There are virtually no basal or HER2 type lobular cancers, at least in this analysis. So looking at the response predictive subtypes of imprint and reprint, and I'll remind you that imprint was associated with immune activation and associated with responsiveness to immunotherapy in several arms of the I-SPY trial, while reprint identifies DNA repair deficiencies, tumors which may then be more susceptible to agents such as PARP inhibitors or those which take advantage of DNA repair defects. When we applied these to the lobular cancers, as you can see here, very few of them are either imprint or reprint positive. In fact, in our cohort, we found less than 2% of the lobular cancers were of the imprint positive type, and an even smaller proportion were reprint positive. When we look at the center group, you can see here that the vast majority are imprint and reprint negative in the lobular category, although there are some that are coming through imprint positive. So in conclusion here, we have confirmed, not surprisingly, that most lobular cancers are MammaPrint low risk, but there's a substantial proportion that are high risk, and one can't assume that lobular histology always correlates with low risk clinical behavior. These data actually certainly complement what we know to be in the MINDACT lobular cancer paper in press or soon to be published, which shows that outcomes for lobular MammaPrint that are high risk are quite similar to those that are ductal MammaPrint high risk, where the histology becomes less important than the genomic risk. It appears, at least by this analysis, that few lobular cancers are likely to benefit from immunotherapy, although there are some that were imprint positive to the extent that that can predict benefit. Let me move on then to two analyses involving looking at ethnicity and its effect on the biology of breast cancer. In this case, we have a poster presentation that was selected for a spotlight presentation with Dr. Mazo Canola from University of Texas. Here looking at MammaPrint, BluePrint, and whole transcriptome patterns in Latin American women with breast cancer in the FLEX study. Here is that fairly complex poster. And as I mentioned, Dr. Mazo Canola was asked to present these data in a poster spotlight discussion session, and these are her slides from that presentation. So the objective here was to understand what genomic differences may exist in the breast cancers of Latin American women, self-described in their ethnicity, compared to non-Hispanic white women and as well as Black women with breast cancer, looking at the genomic and transcriptomic differences, because we know, of course, that there are some differences in the clinical features as well. As you can see on the right, tumors were matched between Latin American women and non-Hispanic white women, but there were certainly clinical differences of which we're all aware. A higher incidence of type 2 diabetes in the Latin population, a higher incidence of obesity or overweight in the Latin population, things that are well known already through demographic analyses. And then when we look at the genomics, we found that the distribution of low and high risk MammaPrint was fairly similar, as you can see there, although importantly, and in a manner that's quite similar to what we have seen in Black women with breast cancer compared to non-Hispanic white women, there is an increased frequency of basal breast cancers as defined by BluePrint. In this case, you can see here nearly 15% versus 9% in the non-Hispanic white population. When we look at imprint, which also seems to be more likely to be positive in basal subtypes, we find again an increased frequency of imprint positive tumors in the Latin American population. Again, holding out some hope that if they were higher, the higher risk tumors may be good candidates for immunotherapy in the future. Again, with the power of the whole transcriptome data in Flex, we can do differential gene expression analyses between different groups of patients. And as we have studied in the past, the effect of obesity on gene expression in tumors, that was performed again here. Looking at a volcano plot on the far right, comparing luminal B, meaning luminal tumors that are MammaPrint high risk in obese women, comparing Latin American versus non-Hispanic white women, we do see significant differences in gene expression, particularly a number of genes that are upregulated in Latin American obese women with breast cancer compared to non-Hispanic white women who are obese with breast cancer. The meaning of these increases, I think, is a subject of intense analysis. And it's important to point out, as we have done this same obesity-related analysis in Black women, it's important to point out that when we compare luminal B obese Latin women to tumors in obese Black women with luminal B tumors, we see no such differences. So something about this biology seems to be in common between Latin and Black women. And the differences, at least that we've seen between the Latin obese women and non-Hispanic white women, seems to be particularly involving immune system activation, interferon alpha response, allograft rejection, etc., on the far right. Immune and inflammatory pathways appear to be upregulated. So the conclusion here was that when matched for age and tumor characteristics, Latin American patients, not surprisingly, had higher percentages of type 2 diabetes, obesity, and importantly, a higher frequency of basal tumors, just as we've seen in Black women, and also a higher proportion of imprint positive, hormone receptor positive patients who may be candidates for immunotherapy. The transcriptomic differences we looked at with differential gene expression between luminal B obese Latin women versus obese non-Hispanic women showed differences in immune response, which may be reflected in that imprint positivity and may also contribute to aggressive biology. While what we did observe, interestingly, was that obesity seems to have the same effect on Latin and Black women's breast cancer biology, differentially from non-Hispanic white women. This and many of our other studies in Flex show the importance of seeking to include diverse patients in this real-world evidence cohort. And Flex is really helping us to try to tease out how ethnicity may affect biology. Along that same line, of course, we have additional data that was presented at San Antonio, derived from our fruitful collaboration with Dr. Sonia Reed and her colleagues at Vanderbilt University Medical Center. We have already presented data as well as a manuscript in press at this time, looking at hormone receptor positive, HER2-negative Black women versus white women in terms of breast cancer biology, and in this case, longer-term outcomes. The Vanderbilt cohort has significant numbers of Black women of all ages, particularly with hormone-positive, HER2-negative breast cancer, as well as 3 and 10-year follow-up, which I'll show you in a moment. Here is that poster presented at San Antonio. The objective here was to continue our analysis of potential genomic differences, which could contribute to the known disparities in outcomes and survival between Black and white women, looking at MammaPrint and BluePrint distributions. For this study, we looked at 568 Black women who had been enrolled in the Vanderbilt BEST study and the FLEX study, which contributed several hundred patients to this analysis as well. I'll point out as an aside that FLEX has enrolled over 1,200 Black women into our whole transcriptome database, and we are continuing to actively seek enrollment of women of all ethnicities. This cohort of Black women was compared to a cohort of white women in the FLEX trial, similar number. All had stage 1 to 3 hormone-positive, HER2-negative breast cancer, matched for age, tumor size, and nodal status between the Black and white women. So what we initially show here, of course, are how well matched these groups were in terms of the clinical features and basic pathologic features of their tumors. As you can see at the very bottom of the table on the left, approximately 3/4 were node negative, about a quarter node positive. Most, of course, were T1 or T2 tumors. There appeared to be a slight increase in the frequency of grade 3 tumors in Black women, not surprisingly. As we know, they have a higher frequency of basal breast cancers, as I will show you in a moment. On the right, you can see the MammaPrint and BluePrint distribution. And the Black women represented in the solid bars, white women in the hatched bars. So it's immediately obvious that there are fewer luminal A tumors in Black women. There are more luminal B or high-risk luminal tumors in Black women, and nearly twice as many high-risk BluePrint basal breast cancers in Black women compared to white women. We've reported these data before. They are similar in terms of these proportions to the increased frequency of triple-negative breast cancers in Black women compared to white women. So we now see a hormone-positive cohort that is genomically basal and biologically similar to triple-negative as well. So in summary of this section, Black patients had significantly more aggressive MammaPrint high-risk tumors, including luminal B and basal-type tumors compared to white patients. We then looked at 3-year relapse-free survival based upon MammaPrint risk, comparing Black and white women. And what we show here, comparing these two populations, is that the 3-year relapse-free survival is essentially the same at approximately 94% overall for Black versus white women. We do see, however, that there is a similar outcome based upon MammaPrint risk categories. Although we know that in both white and Black women, the basal tumors have worse outcomes and a higher likelihood of relapse, even at 3 years. I think the most important aspect of the data presented in this poster are shown here. And that is looking just at the Vanderbilt cohort with 10 years of follow-up, stratified by MammaPrint risk. You have relapse-free survival on the left and overall survival on the right, stratified by low risk in light blue, high risk luminal in dark blue, or high risk basal in orange. And I think the most important aspect here, with now 10 years of follow-up of these patients, is that a MammaPrint low-risk Black woman has an excellent outcome at 10 years, 98% relapse-free survival, and 100% overall survival. Now, why is this important? Well, it's important because Black women with a genomic low risk identified by MammaPrint have excellent outcomes at 10 years, which are the same as those for white women with the same low risk, showing that the MammaPrint low risk category appears to have outcomes that are consistent across racial groups. So these are the key points. As I mentioned, Black patients who are MammaPrint low risk, luminal A, have excellent 10-year outcomes, similar to those observed in a predominantly white population from MIND-ACT, with nearly 9 years of follow-up there. Equivalent patient outcomes may clearly be expected when classified by MammaPrint and BluePrint, regardless of race, something that is not always seen with other genomic tests. Not surprisingly, hormone-positive BluePrint basal type tumors occur more frequently in Black patients, exhibit worse outcomes compared to luminal tumors. And so it emphasizes the importance of finding these women and making certain that they are treated adequately and not undertreated if they're assumed to be endocrine dependent and luminal. Because we've shown in other data that these tumors behave like triple negative breast cancers and may well require triple negative type regimens. Moving on to another important poster with Dr. Joyce O'Shaughnessy as lead author, as well as participation from Dr. Lajos Pusztai from Yale, looking at the neoadjuvant responsiveness of hormone-positive, HER2-negative breast cancers as defined by MammaPrint and BluePrint subtypes. Here is that poster, and these were the objectives. We looked at the high-risk component of MammaPrint, which, as some of you may know, is now divided into high 1 and high 2, with high 2 being at the minus 0.57 and higher in the negative range. This high 1 versus high 2 difference has been observed initially in the I-SPY cohort. And as you may know, high 2 MammaPrint is now used in the SWOG S2206 trial as an enrollment biomarker for the analysis of the potential benefit of immunotherapy in hormone-positive breast cancer. In this study, we looked at the FLEX real-world evidence database with women treated with neoadjuvant chemotherapy and looked at the distribution of high 1, high 2, as well as luminal versus basal subtypes as they relate to pathologic complete response. In this analysis, we looked at 214 women who were hormone-positive, HER2-negative, who had been treated with neoadjuvant chemotherapy. And then we looked at PCR rates stratified by MammaPrint, high 1 and high 2, as well as the BluePrint luminal categories. When looking at the clinical characteristics and the type of treatment received, shown in this fairly busy table, what I'll summarize for you is the following. MammaPrint classified 2/3 as high 1 and 1/3 as high 2. The age, menopausal status, race, etc., lymph node status were comparable between these two groups. There's clearly a difference in grade between high 1 and high 2. 78% of high 2 tumors are grade 3, but not all. And of grade 3 tumors, 59% were high 2. So grade cannot really be used as a surrogate for high 2 tumors. Not all high 2 tumors are grade 3, and not all grade 3 tumors are high 2. It appears that patients with high 2 tumors were significantly more likely to receive ACT chemotherapy rather than 2-drug TC regimens. And importantly, high 2 were 51% luminal by blueprint and 49% basal by blueprint. So a high 2 tumor could be either luminal or basal by the blueprint subtyping analysis. But for high 1 tumors, very few are basal. Almost all are genomically luminal. And again, this is really important, an important biological distinction because of the different clinical behaviors of these categories. So when we look at the rate of pathologic complete response in this hormone-positive, HER2-negative population, based just on MammaPrint, it's clear that high 2 has a much higher likelihood of pathologic complete response than high 1. Now, I know that there's controversy regarding the value of PCR in hormone receptor positive breast cancers because of the assumption that a PCR to chemotherapy doesn't fully predict outcomes when there is hormonal therapy yet to be given. However, that assumption doesn't apply when you have tumors with varying degrees of hormonal sensitivity. And we do have evidence that the high 2 population, particularly those that are basal, may have very little hormonal sensitivity, and therefore PCR may well be an adequate surrogate for event-free survival or long-term outcomes. So taking the MammaPrint high 1 and high 2 and then further stratifying them by blueprint, we get further differentiation of likely PCR rates. So high 1 luminal B appeared to have a PCR rate of 5.8%. When luminal B was high 2, the PCR rate increased significantly. And then as you can see here, if you're basal and high 2, the likelihood of PCR is over 37%. So there's quite a dramatic increase in the likelihood of PCR to neoadjuvant chemotherapy as the MammaPrint index becomes more negative and as the biology changes from luminal to basal. I'll also add for emphasis here that we know that the PCR rate for MammaPrint low risk, which are all luminal, is only 2%, something that we've shown in another study. So we have now this ability in hormone-positive breast cancers to provide real precision in predicting the chemosensitivity of these tumors based upon MammaPrint and blueprint. Multivariate analysis, of course, revealed that high 2 and basal types, as I just showed you, were significantly associated with the likelihood of PCR, where clinical variables were not associated at all. And you can see here that grade crossed the middle line of the forest plot and wasn't really very helpful in predicting the likelihood of PCR, nor was, of course, age or menopausal status, which we know, nor was tumor size or nodal stage. It does appear, interestingly, that there may be a difference in regimen, something that we are looking at and will be presenting in the near future. So the key points here, MammaPrint and blueprint utility is clear to predict the likelihood of achieving a PCR after neoadjuvant chemotherapy in early stage hormone receptor positive breast cancer. And I would argue that for genomically high risk ER-positive breast cancer, neoadjuvant chemotherapy should be a strong consideration, and not just for shrinking of the tumor, but rather for predicting prognosis, since we know from other data that an ER-positive high 2 tumor that does not achieve a PCR has a very poor prognosis, particularly if they are basal. very similar to what we see in triple-negative breast cancers. And so this information, I think, is clinically important and should cause clinicians to reconsider the clinical parameters for applying neoadjuvant chemotherapy in a hormone-positive patient. It's not simply appropriate for large tumors with positive nodes, I would argue, but it's also appropriate for genomically high-risk tumors, which may have biology more similar to a triple-negative breast cancer. So we're making the argument here in this and many other studies that genomic profiling is valuable and informative in neoadjuvant therapy decision-making. We showed increasing chemosensitivity predicted by MammaPrint as the MammaPrint index goes from high 1 to high 2, and that BluePrint adds important additional stratification, as you could see the difference between luminal B high 2 and basal high 2, both of which have a high likelihood of PCR and should be considered, as I mentioned, for neoadjuvant chemotherapy at clinical stages that are applied for triple-negative and HER2-positive breast cancers. So the last poster that I think I'll have time to review today before we close is this poster, which is a trials in progress poster that gave an update on where we are with this important FLEX study. As I showed you in the last 6 posters, an enormous amount of data that can be generated in this huge database, asking a number of different questions, ranging from looking at different clinically recognized subtypes to differences between ethnic groups and the biology of their breast cancers, as well as now neoadjuvant utility as well. So with Dr. Jaime Alberti as lead author here, we gave an update on the status of the FLEX study in the trials in progress section. Here is that poster, which really reviewed the numbers of the different subtypes that we have enrolled, whether it's ER basal patients or HER2 low patients, lobular tumors, as well as different ethnicities being represented from all around the world, actually. As I mentioned at the beginning, we're actually nearing 16,000 now since the data were first submitted to San Antonio. And this really, I would argue, is likely to be the first breast cancer specific whole transcriptome and clinically annotated study with these kinds of numbers. We have already, over the years and in multiple important meetings, peer-reviewed studies, presented 43 sub-studies and 31 abstracts with multiple manuscripts in progress. And importantly, our ability to study different genetic backgrounds as described by self-reported ethnicity is extremely powerful as well. We've now reached, I believe, 1,200 Black women, over 400 Latin women, as well as growing numbers of Asian American and Pacific Islanders, all of whom we think merit specific studies looking at differential gene expression, in particular because we are indeed uncovering, as I've shown you today, important biological differences at the transcriptomic levels, which may help explain some of the disparities we see in clinical outcomes. So with that, I will stop. I know we're at the end of our time, and we'll look through the any questions that have been submitted, and we'll be happy to answer them.
We did have one question that was asking what you meant by basal.
Basal is a subtype identified by BluePrint, which is not luminal and not HER2 type, and very similar in whole transcriptome gene expression patterns to triple-negative breast cancers. In previous data that we presented at ASCO in San Antonio, we did whole transcriptome comparisons of BluePrint luminal compared to triple negative BluePrint basal, hormone positive and hormone negative, and they are identical in their gene expression patterns. So triple negative breast cancers appear to only differ from ER positive basal breast cancers by the absence of estrogen receptor expression. We also know that within the triple negative population defined by immunohistochemistry, that not all of them are actually genomically basal as defined by BluePrint. The BluePrint signature for the basal cancers will identify probably 80% of triple negatives as basal. But we also find when we apply BluePrint to triple negative breast cancers that about 20% come back luminal, indicating some form of hormonal signaling intact. And we think this is likely to represent the LAR subtype that's been described by other methods, the luminal androgen receptor positive triple negative breast cancer, which we're detecting as having intact endocrine signaling, just not through the estrogen receptor, more likely through androgen receptor related pathways. But basal, I consider to be biologically equivalent to triple negative breast cancers.
All right, great, thank you. We have a few more questions. I know we're over, so we will follow up with the additional questions after this. And if you think of any other questions that you might have, feel free to email marketing@agendia.com and we will address them with our medical team. Thank you, Dr. Audeh, and thank you everyone for joining this afternoon.
Thank you.